Hi there. This is Cheryl Parker. I am the president of the American Nursing Informatics Association, and I am honored today to be joined by Donna Summer, the Chief Nursing Informatics Officer at Henry Ford Health System. And they've been doing some phenomenal stuff with what's going on with our COVID crisis. And Donna, thank you for coming here and sharing with us what you've done. I guess I'm just going to start by saying, what have you had to do differently to adapt to this COVID crisis?
Sure. I feel privileged to be able to share what we've been doing. I think one of the things that started us off on the right path was when we realized it was escalating, that we got a group of our leadership from our IT and nursing leadership and said, we need to create the structure so we have it in place to be able to react and respond to the organization. What we are really good at doing, because we did a lot of them in our system, are go lives. So what we did is copy the same structure we did for our Epic go lives. And so we had an incident commander who gathered issues and tickets from operations, and we activated that, which when we activate that, it activates a bunch of other things, like all other projects stop. And the work is then funneled through this group that we call our command center, and we work on them depending on the prioritization that we get from our system incident command or our operational leadership. So we immediately had a response, and we were ready to start. Actually, the day we met, the very next day, we had field tents up doing testing. So we, we're able to support that activity right away. The other thing is just pulling, so once you stop everything, then you have some extra resources. So our PMs that were on all the projects, we started putting into what we call our MACs, which are how do we create departments, because that was the first ask for us. I mean, for the first 2 weeks, we built two departments at least per day for our system.
And when you say departments, what does that mean to you? How did that change?
So it was about creating capacity. So GPU and ICU departments in whatever space was getting redeployed. For us, we might take several weeks to do a MAC, and we were turning them around within 24 to 48 hours, depending on how big or complex.
So like a tent structure would be a department?
Yes, yes. Although we have not actually gone live with our tent structures yet. We have 2 that are in development. We just took every space we possibly could. We built a inpatient unit at one of our clinic sites, and actually in 2 clinic sites that are live that we're trying to put GPU, very low acuity patients on. But mostly we turned ORs into ICU, PACU areas into ICUs, departments that closed because we weren't doing procedures like our rehab units, we made GPUs. So really it was about, at first, maximizing every amount of space in the system and in the hospitals. So we have 5 hospitals, so we were taking requests from all of them as they created their contingency plans.
Okay, that makes perfect sense. I'm curious, how did you change required documentation? Did you make any changes to physician or nurse provider documentation in the system, or create new flow sheets? What did you do there?
So we did. Actually, we were watching what Epic was doing. And so they sent us, thankfully, they were sending us things that they were adding and changing. And so we were watching that, and we saw that they had a new disaster navigator, and they very nicely shared Vanderbilt's new policy and how they were going to reduce required documentation. So we copied that just within the first week of our so we're just now, Friday we'll finish our 4th week of really high intensity crisis management. So we probably within 1 week had created a reduced navigator and removed a lot of required documentation. And I'm really glad we did that for the nurses for sure, but as we redeployed people throughout the system and nurses that were ambulatory nurses and OR nurses, having a streamlined navigator that we just taught to people was so much more easy than trying to teach them the inpatient tools.
Yeah, that makes sense. I know we're doing another interview tomorrow, actually with the group from Epic. So I'm going to be interesting to see how they got to what they decided. And we are sharing the Vanderbilt tools as well. So I'm curious, what other thing did you change any of the routine processes, like say med administration or something like that? Did you make any changes in that workflow?
We did it in med administration. We talked about it several times, and we realized that the nurses had figured out the best way to manage these isolation patients and our high-risk drugs that required dual signature, and they were managing it pretty well. We didn't want to reintroduce too many changes to processes because, well, first of all, it was just hard staffing-wise anyway, just to take care of patients. Then we had new people, nurses who maybe hadn't worked inpatient or given inpatient care for a decade or more in these settings. So we tried to keep things pretty simple. In fact, we just made the decision yesterday we were going to reduce our respiratory therapy documentation because of a fear that we would have to go to manual documentation for some of our vents. But we talked to respiratory therapy, and they knew what they needed to do if they had to do it manually, and so we didn't make any changes. So for documentation, other than what we did with the disaster navigator, which was pretty significant, we have not done it. Now there's a continual challenge not to add to it as people are trying, as we are doing the MSOFA score and the triaging of patients for resources, as that's been escalating over the past few days. It's like, well, the general practice nurses aren't doing Glasgow coma scales. I'm like, no, and they're not going to, and you're not going to add it. That's not their standard of practice. So there's this constant yin and yang as people think they need to add things to it. But we stayed, we cut a lot out of it, and we're going to stick with it. Actually, the row we created that says, I'm going to get the wording wrong. It took us forever to wordsmith it just perfectly, and people still misunderstood. But my assessment is complete, and we're only documenting exceptions. And then we created a box that said something along the lines of no change from my previous assessment, so that those areas that we're doing, especially our intensive care units, which we're doing every 4-hour full assessments, they were able to use that button. Very popular, very popular. Our RT people are asking for it.
Yeah, that makes perfect sense, because it's only talking about not somebody else's assessment, but yours. Personal assessment.
Although I'll tell you, I did get a nurse who asked me, well, if I'm working the next day, can I use it again? I'm like, no, you can't.
This is like this shift.
That's right. 12 hours later, do it, document a new one. You still are only doing acceptance. But it was funny. I laughed when I got it. I'm like, no, I mean, we're trying to make it better, but come on.
Yeah, we're not trying to get rid of all documentation.
That's right. You work one shift, you never have to chart again for the next 3 days,
Yeah, no problem.
Hilarious where we go. No,
yeah,
that's exactly right. They're not thinking.
Although some days we just need a little bit of a laugh. Some days we just
yes, and that was a fun one. Like, okay, no, you can't.
So I'm curious, other ways y'all are using technology. Is there any other ways you're using technology? I've heard iPads, I've heard Nest, I've heard Bluetooth stethoscopes, anything like that Henry Ford's doing?
So we're doing a couple things. Boy, I wish we had gotten our rover implemented before we went live, because we could have used that in a lot of our settings a lot more broadly, but we weren't ready for that. We are using iPads for patients that don't have their own devices to communicate with family. So that's one that we are doing, not broadly, because a lot of our patients have it, but we've been getting more and more at all of our sites. So we had a pilot site, we're moving that out. Getting ready to use the vital sign monitors. I want to say it's Tito is the brand that we're going to be using for kind of a hospital at home model. So that patients that can be discharged home but are still really need inpatient care, that we're going to do some kind of remote monitoring and care. We can do vital signs and send those to my chart. So that's another way we're using technology. Obviously, for those administrative, our remote meetings, thank goodness we had done some build out and some testing, some load testing before this happened, and all meetings went remote. So that was another really good use of technology. Trying to think what else we did. You'd think, we struggled the most with just getting thermometers for screening people. Who knew there'd be a run on thermometers just like toilet paper?
Yeah. Yeah. It's the things we never think of.
Yep.
I'm still trying to figure out the toilet paper thing, but
yeah, me too. Me too. The thermometer one made more sense, but
yeah.
We were all required to screen every employee coming into work, but we didn't have enough thermometers for our units and our employees.
Oh. And so how's your PPE situation there?
Boy, it's just difficult. Our supply people are constantly, they just work 24/7, searching out activity, searching out supplies. We're doing really well with masks. We had a problem with the smaller N95s because they're just in a short supply across the country. Gowns, when you're using 5,000 gowns a day, because you have, in our system, we had over 900 patients in isolation. 700 plus were COVID positive. The others all still in isolation for either they were under investigation or something else. So at that rate, you get a package of 10,000 and you're already thinking to yourself, well, I'm not going to make it through the weekend. So that has been a constant challenge, one that we have managed to stay on top of. But certainly it's every day we report out, how many gowns we have, how many masks we have. Yes.
Yeah, which means somebody's
supply chain are real heroes. I don't know where they're getting from.
Well, and I think back to when I started nursing, because I've been in this gig for a long time, 43 years this year. Everything we had was cloth gowns, cloth masks. We did not have disposables. So, it's interesting that we're almost reverting back to some of the earlier practices that we had gotten away from.
Right. Well, we just got reusable gowns that we're trialing in a couple of our units so that we can launder them ourselves. And we're now, using UV lights to clean our N95 masks, especially those small ones that were short. So there's been a lot of innovation of reusing some of our old technology.
Yeah, bringing back some old processes that we thought were gone, but now make really good. Because if you think about it, when all the gowns were, and we literally laundered them in-house, ran them through sterilizers, put them back out. That we wrapped our own trays in cloth. Yeah. We ran them through sterilization and, in plastic bags. A lot of that's coming back. So interesting.
Yeah, interesting. It is interesting.
I'm curious if you're using, because a lot of places are talking about how they're using telehealth, telemedicine.
Oh, yes.
How are you expanding that out?
So that was when I said there's something else I'm missing. That was it. Our telehealth has exploded. Literally we were doing about 150 visits in a week, and we are on track to probably be by next week 10,000 visits in a week. We closed down. I know it's when it's just like a straight line on the graph, straight to the corner. It's amazing. And that's one of the things I asked them. I'm like, how did you do it so quickly? And we just had a really good team with very clear direction and a standard process. And as they closed down clinics, they increased the video visits. And then we started using, we're Epic customers, so we started using Haiku for visits, and that made it much simpler. And of course, what opened it really was when CMS dropped some of the the regulations and we could actually bill for it. And we didn't have to charge patients up front for the visits. But yes, I mean, it's just growing by leaps and bounds. I can't even believe how many we're doing. It makes me really wonder when we start to recover from all of this, we'll have a new world. And we may not need the same kind of capacity in our ambulatory settings than we currently have.
Yeah, I think that's going to be a very interesting change. I think we're going to end up reassessing a lot of what we do based on this experience. And I think it is going to flavor the future when we finally get beyond this.
Well, in this crisis helped us because we've been trying to get that program up and running well for the past 2 years. And within 2 weeks, we, you know, a lot of barriers got broken very quickly. And here's where we're at, which is wonderful. My husband had a video visit yesterday. It was great.
You know, I'm hearing that same story again and again of it's growing like this. It's working well. Clients are happy. We're happy. Yeah, I think it'll definitely change things. I mean, I'm curious to know, has any of your licensing changed to practice to full capacity of licenses? So, you know, nurse practitioners, PAs, are they practicing any differently in your state now?
Not significantly. They did relax those people who let their licenses expire. They could reapply for them so that they could rejoin the workforce. So I'm aware of many RTs and nurses who've gone back and done that, who retired, who got their license. We are, though, it's interesting, like our CRNAs and our nurse practitioners, we're redeploying them in new roles at our system. But as far as like licensure for the state, I mean, we're giving, our CRNAs have on average 3 roles. They're doing an ICU nurse role, their CRNA role, and then a provider role in those ICU settings. So, you know, depending on which hat they're wearing, that's how they log into the electronic medical record to get the right tool.
Interesting. Yeah.
And that's what we've had to do to be flexible. We sent all sorts of people to the ED, and now the EDs are slowing down, and now the ED is coming to the inpatient to help.
So really just being as flexible as you can with your staffing models and that. I just had a question and it just like fell out of my head. I love that when that happens.
Well, let me talk a little bit about redeploying, because I think that was a real lesson learned for us. You know, a couple days in, we're building more units, we're hearing about ambulatory clinics closing down, and we realized that, you know, we had this way of giving people access into Epic that was very regimented. And so we, you know, the first thing we did is like, how do we expedite this? You know, we've got ambulatory nurses going to go to the inpatient setting. They need training, but they might go tomorrow, and we don't have a lot of time to train them. So one of the most important things we did was say, we're going to give security when asked. And as long as it's an add-on and it's not a change, we're going to give the security, and then we'll reach out and train afterwards, and so that we could respond quickly to the needs of the organization and give people their Epic access. And we're tracking every change we make so that we can reverse them in the future. But that really helped us. And then our training team went to create specific e-learnings and guides for redeployed roles and webinars, and you know, so that we could do it all remotely. So we could just send the link to a nurse and they could watch it, and depending on how comfortable they felt, they could join a webinar. But many of them would be told one day they're going to be, you know, on a medical surgical unit tomorrow. And we'd have to just really rush and be able to do that because the staffing has been so critical.
So that was kind of the question that had popped in my head when you were talking about the CRNAs, that there's really 3 roles they have to fill. So they have to log out and log back in their different personas. Is that correct?
That's correct. Although, you know, ideally, they're going to be in, and this is what they tell us they're doing, although I'm sure it's not, I can see them being the ICU nurse, then as the ICU nurse, and then, oh no, restraints need reordered. So log in as a provider for that patient. But ideally, they should be in a certain role for the day. And in most cases, they're being used as ICU nurses or ED nurses, and they should be using those templates. But we were so short of providers for a while that actually for a short time was more critical than nursing.
Yeah, so just you've got to be able to be really flexible and maybe let go of some of the control that we
Yes.
used to have or used to think we had to have.
Oh yeah. We didn't let anybody get anything in Epic unless they, went to training, and then, how long did it take for training to tell us it was done? And yeah, I don't know. I don't know whether, I hope we won't go back to some of those old processes because they didn't really serve us well.
Yeah, I think we're going to spend a lot of time doing a lot of post assessment of our workflows and saying, okay, does this really need to go back?
Right. Documentation being a perfect example is we shortened it up. We've been wanting to do it for years now. We said we're overburdening nurses. Do we have to go back? Well, some things, yes, we do have to go back. We have to make sure documentation on care plans are happening. But one could wonder, do we need to go back to where we were? Maybe there's a middle state that we should go back to.
Mm-hmm. And I think that'll be a big topic of discussion when this is all over. So Donna, anything in conclusion that you'd like to share with us today?
I think, let's see, what was it? Redeployment was the biggest one. The other thing that I would suggest for people who are like a little further in the wave, so we have 4 of our hospitals are just at the steady state. Our deaths are rising, but our COVID cases are decreasing in the Southeast Michigan area. But we have a hospital in Jackson that's just starting to ramp up as things are moving through. One of the things, and I believe this is probably true of most organizations, is we have a lot of help when we go live with our EMRs, and then we slowly dwindle away our support staff. And when we do that, then we get into an emergency like this, and we're very single-threaded. And, we had staff that were working 12, 14, 16-hour days, and we were 3 weeks in a row. And in the beginning, we're like, oh no, it'd be so hard to teach somebody else. It wasn't that we weren't willing to bring in resources. It was just too hard to do it. But then you have to think in terms of this being months. And you can't keep those people at that level for months. And that's one area where I feel like we should have just insisted as leaders that we should bring in extra help, because those people that we would have brought in would have been strong by now. And then we could have given our people better breaks than, a half a day here, a day here and there. So I think that is a really key point. And the other is we immediately embedded our nursing informatics people in our system incident command. So we have 5 hospitals and a medical group, so we had 6 incident commands that report to the system incident command. What we found is we couldn't get information on what was happening and what was coming without embedding, because those leaders are too busy to help. And so by embedding, we could anticipate and be more responsive to their needs. And then the other piece is when you start making changes clinically, like the MSOFA and the triage policies that are required for resource, getting a clinician who can actually help you is very difficult. And so what you find is, we always have been involved in education, but we literally are helping write policies and create education without our normal experts from our nursing informatics team, because they're supporting the staff nurses on the floor, or they're staffing themselves. So just another plug for why we need nursing informaticists in these roles, because they can do that kind of work when they need to, and our organization needed them to do it. They could then react and respond, but that's a whole different work effort than having to come up with it all from the beginning. Comfort care and the changes in the things we've done for hospice and end of life terminal weans. You know, lots of med changes with that and the recommendations. So really important to have nursing informaticists who can do that work for you.
So I did think of one other thing. Any changes that you made either in dashboards for your executives or providing data and information down to your clinicians at the bedside? Has there been any big change there?
I think probably for our clinicians at the bedside, the MSOFA for our triage commanders is probably the big one, as well as some proning policies and new COVID orders. But those aren't necessarily reports. The MSOFA is a report or an auto calculation for the providers. But we did some improvements to our capacity. So ongoing capacity events, deaths, discharge safely, still really struggling with getting the extubated patients. It's just like everything else, you know, it's only as good as it's documented. And so we struggle getting valid reports there. But that has been really challenging, and even more so challenging are all the outside. We're trying to just communicate to our leaders and our frontline people basic data, but the state and the federal government are asking for even more. And you know, like one thing we had, Vice President Pence, I think they said there were 70 data requests coming from just from our federal government, and does it in Michigan, and then our emergency management team. So this constant, I mean, your analytics people just cannot keep up the churn, and then everything's got a different definition.
Mm-hmm.
So everyone wants to define it a little differently.
Oh yeah, what's a week? Is it Sunday to Sunday? Is it Monday to Monday? Is it?
Oh yeah. Crazy. Those poor people, they just, they finally got a work group together last week and said, okay, what are we going to report out? Because we can't do everything everyone's asking us. And then, you know, what definitions are we going to clearly do? But the capacity manager for just bed has been really powerful in deciding priorities and renaming units so we know exactly what we have, and COVID versus non-COVID units are probably the ones that get used the most often. Lab testing, how many pending?
Mm-hmm.
We were really fortunate. Our lab was one of the first in the country to have our own test. So we turn them around in less than 24 hours now. So we're getting pretty good about reporting that. Yeah.
Excellent. Well, I know I've taken up a lot of your time. Anything else in closing that you've got for us?
No, I just hope and pray everyone does well during this crisis and stays well. And if I can do anything to help, please, you know, feel free to reach out.
Well, thank you so much, Donna. I really appreciate it. And you guys stay safe there in Michigan. I have a warmth in my heart for Michigan. I worked for a Michigan-based company for a long time, so I used to spend a lot of time up there. And y'all take care.
Thank you. You too.